All right, I'm going to go ahead and get started here, and we'll have some more people join us, I'm sure, as we go. But good afternoon and welcome to today's workshop, Recovery in Mental and Behavioral Health Care, Tackling the Hidden Epidemic of Tobacco Use. Before we begin, I want to take a moment to thank each of you for taking the time today to prioritize this discussion about tobacco use and its impact on mental and behavioral health recovery. My name is Emily Koyagi, and I'm the Program Manager for BeWell, which stands for Behavioral Health Wellness Environments for Living and Learning. We'd love for you all to share your name and your organization in the chat so we can see who all is with us today. So please take a moment to do that. And then before we begin, I want to make sure we acknowledge and thank the Kentucky Department for Public Health's Tobacco Prevention and Cessation Program. I'm sure many of you all know Ellen Cartmell, Heather Shaw, and the rest of their team from the state who work tirelessly every day to reduce the number of preventable and premature deaths caused by tobacco. We're so grateful for the support, and the workshop would not be possible without that important support. So thank you so much. The next slide we want to share is our BeWell team. BeWell is a research team housed at the University of Kentucky College of Nursing. Several of our team members also hold joint appointments at Eastern State Hospital, which is managed by UK Healthcare. We provide the essentials of mental and behavioral health support, practice, research, education, scholarship, and service, and are experts in behavioral health integration and change. I would love to take a minute to acknowledge our BeWell team. So if they would be willing to use the hand raise feature and recognize those of our team who are with us today. This workshop would not be possible without all of their support and help. And we're just so grateful for this wonderful team that we get to work with. So thank you all, and we'll have a little applause for our team. I'd also want to mention, you'll see their pictures on this slide, is Doctors Walmsley, Mikowski, Keeler, and Nicoli, who will be helping lead our breakout rooms today. And we're so grateful to them as well. So here is our agenda for today. We have a great workshop planned. First, with Dr. Nicoli's presentation, we'll get to consider not just the state of tobacco control, but the state of tobacco control within behavioral health organizations. As many of us know, the CDC has confirmed that the most common causes of death among individuals living with behavioral health conditions, such as heart disease, cancer, and lung disease, can all be caused by tobacco use. Following Dr. Nicoli's presentation, we will break into our breakout rooms and cover the topics of preventing initiation, promoting tobacco-free spaces, promoting tobacco treatment, and engaging in tobacco treatment. Followed by that, we will have a presentation from our keynote speaker, Dr. Chad Morris, and he will take us through the implementation of tobacco treatment programs within mental and behavioral health settings. Finally, we have the awesome opportunity to celebrate leaders within our own Kentucky communities who are already working towards such integration. So we are really looking forward to our awards presentation, which will happen at the end of the workshop. We will take a couple breaks today. I'll prompt you for those breaks and let you know what time to return. It may be dependent on how we're running on schedule, but we will take a few breaks. On this slide, you'll see on this slide and several others, I have added QR codes. I know sometimes in a workshop, it's easy just to pick up your phone and use the QR code. So that's an option, but also Michelle will be dropping links in the chat when you see these QR codes. So if it's easier to click on the link, you'll have that option as well. So if you want to pull up the agenda, there's the QR code and the link will be in the chat. So just a few housekeeping notes before we get started. We are recording this workshop and it will be posted to our website. So these are the sessions where we're having presentations. Those will be available on our website after the event. You are, of course, welcome to keep your camera on or off, but we do ask that you stay muted if you're not speaking. We really would love to hear from you, though. So during a Q&A after each presentation, you can raise your hand and unmute and share, or you can, of course, ask a question in the chat anytime. We do have approval to provide 3 CEs for this workshop from the Kentucky Board of Nursing and the Kentucky Board of Social Work. So after each session, we ask that you fill out an evaluation form, and you will be asked to record your name if you're applying for, or if you would like CE, and that's our way to provide documentation. So please be sure to fill those out. All of our attendees, though, will receive a certificate of participation for attending. To add a little fun to our workshop, please consider sharing your experience on social media. You can use the hashtag listed there, which is BeWell Workshop 2022. So if you have any favorite sound bites, thoughts, aha moments, please share those on Facebook, Twitter, or Instagram, and always feel free to tag us at UKBHWell. If you have any questions or need any assistance during the workshop today, please feel free to reach out directly in the chat to myself or to Michelle. All right, so with that, we'll get moving on our first session of the day, which is a presentation from Dr. Zimicoli, the State of Tobacco Control in Kentucky's Mental and Behavioral Health Organizations. Dr. Acoli is the Executive Director of BeWell and a professor at the UK College of Nursing. He also directs both the Tobacco Treatment and Research and Evidence-Based Practice Services at Eastern State Hospital. His primary research focuses on enhancing substance use treatment, particularly tobacco use, among people living with mental and behavioral health challenges. He is internationally recognized for developing and integrating tobacco treatment approaches within mental and behavioral health systems, as well as training tobacco treatment providers. Most recently, Dr. Acoli was inducted into the Sigma Theta Tau International Nurse Research Hall of Fame. Dr. Acoli is also a board-certified psychiatric mental health nurse practitioner. And currently, in his spare time, although we know he has none of that, he is serving as president of the American Psychiatric Nurses Association. So welcome, Dr. Acoli, and I will stop sharing now and let you pull up your presentation.
Thank you so much, Emily, for that introduction. Okay. And thank you all so much for coming out on this lovely Wednesday afternoon to join us at our workshop. We're truly excited about the opportunity to speak with you regarding this matter of tobacco control within mental and behavioral health organizations in Kentucky. I started out my career as a nurse working at Eastern State Hospital, which is our state one of the state psychiatric facilities in Kentucky. And I remember how often in those days, I won't quite tell you when that was, but one of the frequent opportunities we gave our patients was to go for a smoking break as long as they behaved, took their medications, and did what they were supposed to do for their treatment. And I remember thinking how counterintuitive it was that the way we reward our patients for doing behaviors that would promote their own health was to give them an addictive substance that we know harms and kills them, and also even has a hindrance to their ability to achieve recovery. I'm really glad that we've come a long way since then. And in Kentucky, we've been able to bring in a lot of tobacco control measures that are improving the lives of many of the people that we serve. But I'd like to talk again today just about our current sort of situation in terms of tobacco control in our mental and behavioral health organizations. So I'd like to first acknowledge the Kentucky Department for Public Health Chronic Disease Prevention Branch and Tobacco Prevention Cessation Program, especially Ellen Cartmel, Heather Shaw, Curtis Flynn, who have been such great partners in addressing this issue of tobacco control in the state, but even this focus that we now have for mental and behavioral health populations, which in a sense could be said as the last frontier of populations severely affected by tobacco-related illnesses. I'd also like to acknowledge our partnership with the Kentucky Department of Medicaid Services, which helped us out in some of the early programming that we did to advance tobacco treatment specialist training in Kentucky. The main learning outcomes for today, I'd like to discuss some of the prevalence of tobacco use among people living with mental and behavioral health challenges in Kentucky and understand factors which cause people living with mental and behavioral health challenges to continue using tobacco. And then we'd like to conclude with two main parts. One, we'd like to discuss some tobacco control initiatives that we can use and hopefully you can take home with you to begin addressing issues of tobacco use among this population, but also some resources that exist in the state with which you can potentially partner or use in addressing this issue within your own organizations. So let's start with some background and significance. I'd like to talk a bit about tobacco and its history within the United States. It's important to understand that tobacco as a plant has been used for many, many years, thousands of years, and it started out primarily as a ceremonial product used in the prayers of the Native Americans in a lot of the rituals related to spirituality. By 1612, it became a cash crop among settlers in Virginia. It became a crop that began to be traded for cash. For our history in Kentucky, by 1787, so over 300 years ago, it became an important commercial crop in Kentucky. By the 1800s, there became diversified products, including pipes, chew, roll your own cigarettes, cigars. And by 1865, the first commercial cigarette machine was developed by Duke Washington in North Carolina. And by 1881, their cigarette making machine was developed and originated the American Tobacco Company. By 1902, Philip Morris, which is almost synonymous with tobacco, began producing their most famous brand, the Marlboro brand. And in 1914 to 18 and 1939 to 45, unfortunately, cigarettes were marketed to our servicemen during World Wars I and II, was given to them freely, daily, and it contributed a lot to the addiction that we see in these populations. When we consider diversified products, there are different types of tobacco products, and they fall mainly into two main categories. The first are combustible or heated, and these include things like the cigarettes, cigars, cigarillos, some hookahs, water pipes, as well as the new kids on the block we call the electronic nicotine delivery systems, often called vapes or e-cigarettes. And then we have some of the non-combustible products, which includes the snus, the chew tobacco, and some newer kids on the block, the dissolvable products. The key is that tobacco products contain nicotine, and nicotine is the pharmacoactive substance in all tobacco products that is addictive. Now, it's important to understand that the tobacco plant produces nicotine as a way to protect itself from insects. So nicotine is actually an insecticide, and also it's used for, it's a pesticide used for rodents. Similar to the coffee plant that produces caffeine, another addictive substance to protect itself, humans have just found ways to titrate and use these addictive substances in different products in a way that doesn't kill us, as pesticides would, but causes addiction. In fact, the US Surgeon General in their 1988 report said that nicotine is the drug in tobacco primarily responsible for addiction, and that the pharmacological and behavioral processes that underlie tobacco addiction are similar to those that determine addiction to other drugs, such as heroin and cocaine. When an individual actively uses tobacco, 82 to 92% of the inhaled nicotine is absorbed. And this is approximately 2 to 3 milligrams that are absorbed from every cigarette. This increases the heart rate, constricts the blood vessels, acts on the central nervous system, and it imparts a feeling of alertness, well-being. These are some of the addictive properties of nicotine. In terms of the addiction process, when nicotine binds to nicotinic acetylcholine receptors in the brain, it causes a release of dopamine. And dopamine is our feel-good drug or pleasure. It's something endogenous. It's naturally occurring in the body. It gives people a sense of pleasure and calm. As the dopamine decreases between cigarette puffs and inhalations, people may begin to experience withdrawal and symptoms of irritability and stress. So the tobacco user begins to crave nicotine to restore those feelings of pleasure and calmness. And tobacco users will typically titrate their tobacco use, to get as much of the nicotine from it. At first, it started with increased pleasure or desire for pleasure, but then there's a switch where it becomes a desire to avoid withdrawal and cravings. So this is sort of the cycle that people experience with nicotine addiction. It's interesting to think about nicotine as a drug class. So according to the DEA, there are about 5 main categories of substances, and they fall into the opioids, hallucinogens, stimulants, drugs of concern, and depressants. And you'll notice that nicotine falls into both a stimulant or a depressant, similar to alcohol. So when we have nicotine used in high doses, it gives a stimulant effect. Whereas when nicotine is used in low doses, it gives a depressive effect. So you might hear people saying, well, I feel kind of bored, so I smoke. They may be using nicotine in that response in order to have that stimulating effect. Whereas you may hear other people saying, look, I'm really stressed, and so I'm smoking. Once again, they may be using nicotine to get that sort of depressant effect. So nicotine is a substance that's often used depending on the mood of the user. But the challenge is not just the nicotine, it's the delivery system for tobacco. So cigarettes in themselves contain over 600 ingredients and 7,000 chemicals when it's burned. 69 of those chemicals are known carcinogens. In other words, it is without a question of a doubt that cigarettes kill. Not only that, but when we think about the illnesses that are associated with tobacco use, tobacco affects every single body system. It's important to also understand that tobacco use is primarily initiated by 80 to 90% of people before they are adults. So typically in their teenage years, or some in Kentucky in the preteen years, which means that tobacco use is also primarily a pediatric illness. It is an illness of children and adolescents. I think the CDC sort of got a focus on this issue of tobacco use among people living with mental and behavioral health disorders in their 2013 article, where they said adults with mental illnesses are 70% more likely to smoke than adults with no mental illnesses. Prior to this focus on this population, we could say that tobacco use had been a hidden epidemic. And to some extent, even though more visible, it's still, like I mentioned, the final frontier. The population of individuals living with mental and behavioral health challenges continue to have disproportionately affected tobacco use prevalence and related disease burden. Just as an overview, when we think about the rates of mental health challenges or mental illnesses and substance use disorders in Kentucky, we can see that Kentucky compared to the US, I'm looking at the blue bars based on the Mental Health America data. Kentucky has a slightly higher proportion of those living with mental illnesses compared to the general US population, and about the same in terms of substance use. So almost 1 in 10 individuals in Kentucky have a adults in Kentucky have a substance use disorder, whereas 1 in 5 adults in Kentucky have a mental health challenge. When we consider Kentucky and the US in terms of tobacco use, nearly 1 in 4 adults in Kentucky continue to use tobacco products, whereas we're looking at about a 12.5% adult prevalence in the US. Kentucky continues to rank highest in the US. It ranks second among adult tobacco use prevalence. We just fall short to West Virginia. Now, this data is a bit dated. It's nearly 10 years old, a little more than 10 years old, but it's a significant piece of information that we had when the CDC began addressing this issue of tobacco use among people living with mental and behavioral health challenges, and it has Kentucky data. So when we look at Kentucky, at least again, these are about 10-year-old data, but when they compared individuals living with any mental illness who use tobacco compared to those without a mental illness who use tobacco, those who with a mental illness using tobacco were almost 1.5 times more likely to use tobacco compared to those without any mental illness. So this is presenting that there is a gap in terms of tobacco use among people living with mental illness compared to those who are not. And in fact, when we look at a decade-long data, 10 years of the changes in the adult prevalence of tobacco use, the monthly cigarette use, and this is based on data from the Center for Behavioral Health Statistics and Quality from the National Survey on Drug Use and Health. There has been a consistent decline in overall tobacco use prevalence rates, but the red bar are individuals with any mental illness and the blue bar are those with no mental illness, and the gap has persisted. Again, this illustrates the disproportionate tobacco use prevalence we continue to observe in this population. When we understand clinical groups, these are typically individuals who are in treatment, who live with a mental or behavioral health challenges in treatment. We observe that tobacco use rates are even higher in some of these clinical groups. So people with substance use disorders represented by the bars on the right, the white bars, compared to those with more chronic mental health challenges or mental illnesses represented by the black bars, we see that those with substance use disorders continue to use tobacco at rates that are nearly 80 to 90%. And we see still high proportion of use in the population of those with a primary mental health disorder. So now that we've seen, and I hope I've convinced you, and I'm sure you're quite aware that tobacco use is such a challenge in this population with the high prevalence rates, we'd like to understand why this use in this population tends to persist. Several studies over the years have demonstrated that there are genetic reasons and polymorphisms in genes that make individuals living with mental illnesses more susceptible to tobacco use, and perhaps vice versa, where people who are using tobacco, we find are more susceptible to having mental health and substance use disorders. So there have been clear genetic markers demonstrating a shared polymorphism between smoking and major depressive disorder, as well as post-traumatic stress disorder, PTSD. and for people living with schizophrenia. In addition, when we consider some of the biobehavioral relationships, an example I like to give is you're all focused on me as I'm discussing. And well, there was a knock on my door, and I'm sure some of you may have heard that. But as you're focused on me, your ability to focus is something we call sensorimotor gating, which means you're able to gate out other distracting stimuli, hopefully. I'm sure there are cats walking across the screens and children, who knows what, doing things in the background. But as you're focusing on me, you're able to gate. Individuals with schizophrenia have a dysfunction in their ability to gate. However, when they have nicotine on board, they are able to actually gate. So nicotine may have some functional ability in terms of improving concentration, memory, but don't forget that all the other 7,000 chemicals in cigarettes kill. In addition, there have been studies that demonstrate there might be some things in the cigarette smoke, possibly the acetaldehyde, that reduces brain levels of monoamine oxidase inhibitors. And then in addition, nicotine itself can be an anxiolytic. Again, when it's used in those smaller doses, it tends to act as a depressant and may have some anxiolytic functions in lower doses. The final main reason why individuals living with mental behavioral health disorders may use tobacco at higher rates is because, as I illustrated in my example when I began the talk, working at a state psychiatric facility, we promoted the use of tobacco in order to reward behavior. In a sense, it was used as a token economy. In the past, not so much now, but individuals living with mental behavioral health challenges were encouraged to use tobacco as a form of socialization. And it's an anecdote that is commonly heard where individuals say, I was a non-smoker or a non-tobacco user until I actually went into addiction treatment or mental health recovery treatment. And that's when I began to use tobacco. So this portion illustrates that tobacco use is still largely a normative behavior in mental and behavioral health settings. And we need to find ways to denormalize this behavior and demonstrate that actually tobacco treatment seeking behavior should be the norm. Sometimes we may encounter by some of our colleagues resistance or questions of why do we want to address tobacco use in this population? And the best way to address such resistance or questions, I'll place it, or the myths that occur, is we address it with data. And so one I've often heard is they really don't want to quit. They actually like using tobacco. Well, when you look at data, we see that enough studies are demonstrating no, individuals living with mental and behavioral health challenges do want to stop using tobacco because it is affecting their health and it is addictive. And they're aware of this, but they need help often in addressing their tobacco use disorder. Another myth we may hear is, well, why waste your time? They're not able to quit. Well, again, studies have shown us that they are able to quit, especially when they're provided evidence-based tobacco treatment services. And another important aspect is that tobacco use hinders their mental health recovery, but smoking cessation or tobacco use cessation actually improves their psychiatric symptoms. So if we're armed with these data sources and these statistics, we're able to counter some of the myths that may still persist in mental and behavioral health settings regarding tobacco use cessation in this population. Some of the challenges that we've observed that continue to persist is that there's a paucity, there are poor tobacco treatment services delivered in behavioral and mental and behavioral health settings. And sometimes the conventional tobacco treatment programs that we know may work in the general population may not address the unique needs of people living with mental and behavioral health challenges. For example, some of the existing programs that tend to work for people in the general population may have shorter durations. And people living with mental and behavioral health challenges may need a longer time in order to engage in treatment to be able to stop their tobacco use. Again, some of the traditional tobacco treatment programs, the conventional ones, they may use nicotine replacement therapy or medications at doses that are based on product monograph, but people in our population tend to use tobacco at much higher rates than based on product monographs. So we may have to be creative in using existing nicotine replacement and other pharmacological aids in assisting them to stop using tobacco. An example of that is this third point, that when you look at several of the studies that established the pharmacotherapy products that can be used for smoking cessation, in those randomized controlled trials, they always excluded people living with mental and behavioral health challenges from their samples. So now to apply these existing recommendations based on those studies to our population, we find that they are overall effective, but often they need to be tailored to the population to optimize their effectiveness. So what are some of the tobacco control initiatives that we see in Kentucky to address tobacco use in these populations? One, it's important to remember that it is our responsibility as care providers to address tobacco treatments. It is our responsibility. We are often reluctant because we may buy into a lot of the myths that I had spoken to you about earlier, or we're reluctant because we may not feel trained. But the good news is, with the myths, we have data to say that we can do this. We are successful in treating tobacco use in these populations. And with the lack of training, there are great training opportunities to be able to engage people and build our confidence to address tobacco use in these populations. The Centers for Disease Control and Prevention, they have recommendations specific to mental and behavioral health settings. And the first recommendation is that we need to stop practices that encourage tobacco use. We shouldn't be providing cigarettes to patients or any form of tobacco products to our patients. And we should not allow staff who care for these to use tobacco on site. Again, the idea is not that we are taking away an individual's autonomy. People can choose to do whatever they want, but we can limit where they do certain activities in order to promote wellness, okay? An example of this that we like to use in tobacco control world, and forgive me for its crudeness, is, people just shouldn't pee in a swimming pool, you know? We're not stopping people from peeing, just don't do it in a public swimming pool. In the same way, we're not stopping people from using tobacco, just don't use it in public spaces. So the second recommendation along with that is to make campuses 100% tobacco-free. And it's important to include tobacco treatment as part of mental health treatment and wellness. Again, bring in the normal idea to normalize that tobacco treatment is part of mental health and is also part of mental illness treatment. But when we look at Kentucky versus the United States, there was a study done in 2016 that assessed the capacity and the different approaches of different mental health treatment facilities throughout the United States in addressing tobacco. And you can see that in all areas of screening, offering counseling, offering nicotine replacement therapy, and smoke-free campuses, Kentucky continues to fall short, which means that we have an opportunity to address these specific areas. In the same survey, when they examined substance use treatment facilities, again, Kentucky falls short from the national sample. And these aspects that were assessed are what we know to be evidence-based approaches and best practices in addressing tobacco for these populations. So again, there are opportunities for us to improve our ability to address tobacco within mental and behavioral health settings. Our BH Well team in 2019 to 2020 conducted a survey where we wanted to understand among community mental health center programs in Kentucky, their capacity as well as their initiatives in addressing tobacco treatment. And we asked about how many of them had a written policy, a written tobacco use policy, and that was really good response. At least 82% have that. Nearly 60% said they at least have no smoking signs within their specific healthcare settings. But only about nearly 30%, 28% reported that they provided tobacco treatment services. Now, this was based on a sample of 159 different programs within these different community mental health centers, but it begins to give us a picture of the opportunities to address tobacco control within community mental health centers in Kentucky. We also asked in the same survey among those programs, their use of evidence-based tobacco treatment programming, which is often used, called the 5 A's: ask, advise, assess, assist, and refer or arrange. And we found that although most of the programs said that their healthcare providers ask clients or consumers about tobacco use, they don't as often advise them to stop using or assess their readiness to stop using or provide assistance to them to stop using or refer them. Again, these are promising results that something's happening, but there is opportunity for growth and improvement. So I'd like to just talk a little bit more about some of the opportunities that we have for tobacco control in Kentucky for people living with mental and behavioral health challenges. And I like to frame this aspect of the presentation in terms of the national and state tobacco control program goals. There are 4 main aspects of these goals, and they are to eliminate exposure to secondhand smoke, to promote tobacco treatment among adults and youth, to prevent initiation among youth and young adults, and to advance health equity by identifying and eliminating commercial tobacco product-related inequities and disparities. So I'd like to see sort of what are the opportunities we have in Kentucky to address some of these points. So first, let's talk about eliminating exposure to secondhand smoke or making places tobacco-free. First, I want to make you aware of this, that there are several toolkits from different states and different programs, and we'll have our very own Chad Morris, who was instrumental in developing the Dimensions Toolkit. It's going to be our keynote speaker, and he'll talk about different ways that we can make mental and behavioral health settings tobacco-free. So these toolkits provide step-by-step guides of best practices whenever we would like to start initiating discussions or intervening in tobacco-free spaces, especially within mental and behavioral health settings. Another avenue that isn't really touched at all is addressing tobacco-free policies within supportive housing. So a study in 2018 found that after a tobacco-free policy was implemented within supportive housing, there were decreases in indoor smoking, there were decreases in the proportion of residents who identified as current tobacco users, and there was increased support for the policy even among the current smokers. Although there was no specific change in the residents who smoked, the outcomes of increasing the awareness of tobacco use and actually that people supported these policies kind of encourages that we may need to start looking at voluntary tobacco policies in the areas where our clients and consumers with mental and behavioral health challenges live. Another aspect is promoting tobacco treatment, the second aspect of the national guidelines. Just want to make you aware that we have a fabulous program, Quit Now Kentucky. And what makes it really fabulous is that they even have scripts from those who intervene on the call lines. They have scripts that have trained them to address people living with mental and behavioral health challenges. So if you have patients who want to quit, you have a great referral source through the Quit Now Kentucky. And as long as they identify themselves as having a mental behavioral health challenge, they will be linked to a trained counselor, a quitline counselor, who will help them in their efforts to stop using tobacco. A study by Dr. Morris, again, demonstrated that when you use these quit lines, this was based on National Jewish data, if you use these quit lines among a control group of individuals who had some coaching calls, as well as focusing on mood management as well, compared to those who just had treatment as normal, you do begin to see a decrease, or at least an increase in those who stop using tobacco. They weren't statistically significant differences, but they began to demonstrate that the quit lines may have some impact in addressing tobacco use in these populations. Another excellent program through the American Lung Association is Freedom from Smoking Clinic programs. And these programs are available in different mental health and health department centers throughout Kentucky. And they may be a good program that you would want to link your clients and your consumers with mental and behavioral health problems after seeing them in your programs. Another opportunity through our Be It Well program is to advance what we call behavioral health quit and win contests. So behavioral health quit and win contests are an opportunity where individuals who are tobacco users can enroll in a contest to stop using tobacco for 30 days. And if they're successful, they can win a prize of some sort. It could be cash prize or something else. Now, in general, the quit and win contests are exciting, and they are important strategies to engage people in tobacco cessation. In and of themselves, they may not have long-term sustainable quit rates or cessation rates, but what they do is individuals who are contemplating tobacco use, this becomes an incentive, contemplating tobacco cessation, this becomes an incentive to actually begin to explore ways to engage in tobacco treatment. There's some evidence from some studies in Medicaid populations in Texas to show that when you provide incentives within community mental health clinics, individuals are actually able to see or achieve cessation. Another opportunity for healthcare providers is the tobacco treatment specialist training and this is through Breathe at the UK College of Nursing. And this training is a course that will equip individuals in understanding tobacco control and tobacco cessation. And it provides 27 hours of self-paced training. It's completely virtual, so you can do it at your own pace. And the key is it will build the confidence and skills that individuals would need to address tobacco treatment. And it would be really neat if you don't yet have a trained tobacco treatment specialist in your organization. Please talk to us about how you can be linked with this program. Okay, what about preventing initiation among youth and young adults? For people living with mental and behavioral health challenges, this seems to be the hardest part in understanding how and if we need to tailor prevention initiatives for kids who have mental and behavioral health challenges. We know from the research that kids, adolescents who have mental and behavioral health challenges are much more likely than their peers without mental and behavioral health challenges to become tobacco users and other substance users in the future. But there really is no data or studies that are targeting prevention initiatives specifically for these populations. But in Kentucky, we have programs which address tobacco cessation and tobacco prevention issues among youth, such as the Kentucky Youth Advocates. So there are programs that we can get involved with and see how to partner or collaborate with them in their successes. The Kentucky Department for Behavioral Health and Intellectual Disability also has prevention and promotion branch, and they also address ways to prevent substance use among people living with mental and behavioral health challenges. Finally, in terms of advancing health equity by identifying and eliminating commercial tobacco products, this is the fourth main national goal or strategy. It bears to say that an important strategy to reduce tobacco use in the general population, tobacco use consumption, is the excise tax. And Kentucky ranks 36th in the nation in terms of our excise tax. That's not great. We fall below the US average. But it's interesting that a study in 2010 actually demonstrated that if there is a 10% increase in cigarette excise tax, it translates to an 18% decrease in smoking among those with alcohol, drug, or mental disorders. So some of our population-based policy strategies can have trickle effects that can benefit our specific population as well. Well, thank you for your attention. And again, I applaud each of you that you are here and want to understand ways that we can enhance the work that we're doing to address tobacco use in these populations. And I'd be happy to answer any questions that we might have. Emily, I'll give it back to you.
Well, I was going to say, feel free to unmute and ask a question or raise your hand, or you can drop something in the chat. That was a wonderful presentation. And I know Dr. Okoli provided a lot of resources that we can all take back to our organizations and use. We do have a question, Dr. Okoli. It says, how are organizations tracking their successful quits? A great question.
That is a great question. And I almost want to ask that question back to you. We're going to have our next session where we're going to address some of the specific aspects of what organizations are doing, and it will be a good networking and brainstorming section. So Holly, who asked that question, maybe your question will be answered from different organizations. But what I would say is the toolkit that I mentioned, it actually provides some good measures that can be consistently used across organizations to track cessation and treatment rates.
Any other questions or comments?
Dr. Aculli, this is Heather. Could you talk just a little bit about the importance of nicotine replacement equivalencies? You talk a lot about the high smoking rates, especially among, I noticed specific diagnoses, some were extremely high. So what impact does that have for health providers and tobacco treatment specialists when considering how to support someone stopping tobacco use?
It's an excellent question, Heather. And, I am a psychiatric nurse practitioner, so I see patients, and it's not uncommon for the patients that I have to be using tobacco at rates as 2 packs or 3 packs a day. Actually, there's an excellent video on the Quit Now Kentucky website about a lady who says she used like 5 packs a day. And when we are trying to address nicotine replacement in terms of when people are using such high doses, we borrow from addiction theory. And, when we look at things like methadone replacement therapy, some other medication assisted treatment models, you typically want to replace the amount of the substance being used with an equivalent amount of pharmacotherapy. So if a person is smoking, let's say about 20 cigarettes per day, a pack a day, you would want to give that each cigarette is about, they absorb from each cigarette something from 1 to 2 milligrams. So you want to use a nicotine replacement product that replaces how much they absorb. If they're using about 20 cigarettes per day, absorbing 1 to 2 milligrams, you want to give them at least a 20 milligram patch, which will replace how much they're absorbing. So if they're using 2 packs a day, 40 cigarettes, you're going to be replacing with 40 milligrams of the patch. What I tend to find is I ask a patient, oh, have you tried the patch? Oh, yeah, I tried that. That didn't work. They're smoking 20 cigarettes a day. Well, how much patch did you use? Oh, 7 milligrams. So it becomes an opportunity to educate them about the proper use of these nicotine replacement products.
Hey,
So,
Zim, it's Stephanie Keeler. Can I tag onto that? And when you talk about nicotine replacement, what about also adding that the like Chantix, or I forgot the generic name for it, but is that the more common practice, or is it sticking with like nicotine replacement therapies only?
no, that's a good question. And with Chantix, Chantix was actually designed specifically for smoking cessation. It's a very novel medication in that respect. And with Chantix, you should use it according to the product monograph, because what Chantix does is it actually competes with nicotine binding sites. And so when a person takes it as a pill and then they try to use nicotine on top of it, the Chantix molecules bind the receptors for nicotine acetylcholine receptors. And so while they're trying to smoke while using it or using any tobacco nicotine containing product, the receptors are occupied. But what we do find is typically people are giving 1 to 2 milligrams of Chantix, and some people may need more, but not necessarily based on how much they use tobacco.
So it might be more of a trial and error, like if they feel like they might have to report back sooner to their provider and to determine its effectiveness.
Yes. And
Okay.
typically the most effective medication for tobacco cessation is Chantix.
Okay. Thank you.
You're welcome.
All right, well, if we don't have any more questions, I'll go ahead and share my screen again. Okay. All right, so after each session, we would like to ask for you all to fill out an evaluation form. You can use that QR code again if you have your phone handy and that's easier for you to do that. But Michelle is also dropping the link to the form in the chat. Michelle, that didn't come through as a link. I think, can you try to put that in your browser and then, yeah. That's,
Yep, I was doing that as you
oh,
were
okay,
talking about it.
sorry. Sorry. Okay, so if you all want to take a minute to fill out your evaluation, we can go ahead and start our break. I'm going to leave this slide up. I do have, just a break slide here, just to remind you all that if you want to share your thoughts on social media, our hashtag is BeWellWorkshop. But I'm going to go back to this so that you all have it up. We will take a break now, and we may need more time at the end, so let's stick to the 10 minutes. So we'll gather back here about 7 minutes after 2, if that's all right with everybody. We will see you soon. Thank you.